Good day. Today I am discussing spinal trauma. Trauma to the spine can cause a vertebral spinal column injury, a spinal cord injury, or both. The vertebral column is composed of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 fused sacral, and 4, usually fused, coccygeal. The axial vertebrae, C1 and C2, are anatomically unique in that they are designed for rotary motion. The odontoid or dens of the axis, or C2, is held against the atlas, or C1, by the strong transverse ligament. The remaining vertebrae share some common anatomical features. A typical subaxial vertebra is composed of an anterior body and a posterior vertebral arch. The vertebral arch is comprised of 2 pedicles, 2 laminae, and 7 processes, 1 spinous, 2 transverse, and 4 articular. These articulations enable the spine to engage in flexion, extension, lateral flexion, rotation, or circumduction, which is combination of all movements. The orientation of these articular facet joints changes at different levels of the spine and accounts for variations in motion of specific regions of the vertebral column. Due to its inherent flexibility, the cervical spine is the most commonly injured region of the spinal column, with most injuries occurring at the C2 level and from C5 to C7. The second most common region of injury is in the thoracolumbar transition zone. A series of ligaments serves to maintain alignment of the spinal column. The anterior and posterior longitudinal ligaments run along the vertebral bodies. Surrounding the vertebral arc are the ligamentum flavum and the supraspinous, interspinous, intertransverse, and capsular ligaments. Between adjacent vertebral bodies are the intervertebral discs, consisting of a peripheral annulus fibrosus and the central nucleus pulposus. The intervertebral discs act as shock absorbers to distribute axial load. When compressive forces exceed the absorptive capacity of the disc, the annulus fibrosus ruptures. This allows the nucleus pulposus to protrude into the vertebral canal, and this may result in spinal nerve or spinal cord compression. The spinal cord is a cylindrical structure that begins at the foramen magnum, where it is continuous with the medulla oblongata of the brain and extends down the spinal canal to the first and second lumbar vertebrae. The spinal cord gives rise to 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Each spinal nerve emerges through the intervertebral foramen corresponding to the appropriate spinal cord level. The lower nerve roots form an array of nerves called the cauda equina. Given the multiple axes of motion of the vertebrae, they can be injured via several mechanisms and present with a number of different injury patterns. When the mechanism of injury is flexion, the injury would be anterior subluxation or hyperflexion sprain. It's usually stable but depends on the integrity of posterior ligaments. It's usually seen in the cervical region of the spine. Anterior subluxation produces ligamentous failure and may have no associated fractures. Plain films can be normal. However, significant ligamentous injury can display anterior soft tissue swelling, a widening of the spinous processes at the level of injury or fanning, posterior widening of the intervertebral space, and cervical disc space alignment of greater than or equal to 11 degrees between adjacent spaces. Other flexion injuries include atlantoaxial dislocation, which is unstable. Since it involves the atlas and the axis, it's found in the cervical vertebrae. Transverse ligament rupture without an associated fracture can occur in older patients from a direct blow to the occiput. Radiographic diagnosis relies on measuring the predental space, which is the space between the posterior aspect of the anterior arch of C1 and the anterior border of the odontoid. A predental space of greater than 3 mm on a lateral radiograph or 2 mm for CT images implies damage to the transverse ligament. Greater than 5 mm implies rupture of the transverse ligament. Bilateral interfacetal dislocation is also unstable and often seen in the cervical spine. Bilateral interfacetal dislocation or locked facets occurs when the articular masses of one vertebra dislocate anteriorly and superiorly from the articular surfaces of the adjacent vertebra below. Disruption of all ligamentous structures occurs. On radiographs, the vertebral body is dislocated anteriorly greater than or equal to 50% of its width. These injuries usually present with neurologic deficits due to compromise of the intervertebral foramen unless the dislocation is only partial in perched facets. Simple wedge through compression and fractures which are usually stable may occur on the cervical vertebrae. It is the most common thoracic fracture, so it could also happen in the thoracic vertebrae. A vertebral wedge fracture typically involves a fracture of the superior end plate of the vertebral body while sparing the inferior end plate. An isolated simple wedge fracture is stable, but the presence of significant posterior ligamentous disruption can make the injury unstable. A simple wedge fracture is differentiated from a burst fracture by the absence of a vertical fracture of the vertebral body and lack of bulging of the posterior vertebral border. Spinous process avulsion or Clay-Chauvelur's fracture is a stable fracture that occurs in the cervical spine. This is an avulsion of the end of one of the lower cervical spinous processes, usually C7. It is thought to be caused by strong muscle contractions pulling on the bone via the ligamentous complex. It is not associated with neurologic compromise. Flexion teardrop fractures are highly unstable and occur on the cervical spine. Extreme hyperflexion causes complete disruption of the spinal ligaments at the level of injury. The teardrop is the anteroinferior portion of the vertebral body that is separated and displaced from the vertebral body by the anterior spinal ligament. Fanning of the spinous processes may be present with or without fracture. A sagittal fracture through the vertebral body may be seen on CT. Anterior spinal cord syndrome is associated with this injury. Flexion rotation spinal column injuries include unilateral facet dislocation, which is stable unless associated with an articular mass fracture. It usually involves the cervical spine. A unilateral facet dislocation occurs when the articular mass and inferior facet on one side of the vertebra are anteriorly dislocated. On a lateral radiograph, the involved vertebral body will be displaced less than 50% of its width. On the anterior view, the spinous process at the level of the rotation will be pointing towards the side that is dislocated. Fractures of lateral mass can be unstable. They usually occur on the cervical spine. It typically presents with severe neck pain and sometimes radicular symptoms. It may be associated with Brown-Séquard syndrome or vertebral artery injury. Therefore, some experts feel that magnetic resonance angiography should be done in all patients with this lesion. A pillar fracture is a type of lateral mass fracture that consists of an isolated vertical or oblique fracture through the lateral mass. The adjacent lamina and pedicle remain intact. The fractured articular mass is displaced posteriorly and may be visible as a double outline on the lateral radiograph. Flexion distraction injuries include anterior compression with associated transverse fracture through the vertebral body. This is an unstable injury, and it occurs on the thoracolumbar spine. These injuries are associated with seatbelt injuries, especially when lap belts alone are used. Radiographic findings include posterior vertebral wall fracture, increased height of the posterior vertebra, and fanning of the spinous processes. The chance fracture variant presents with minor anterior vertebral compression and significant distraction of the middle and posterior ligamentous structure. It often occurs from T11 to L2, which is the thoracolumbar transition zone. These injuries are often misdiagnosed as an anterior compression fracture. They may require CT to visualize and are often associated with intra-abdominal injuries. Vertical compression injuries include Jefferson burst fracture of the atlas, which is potentially unstable. Since it affects the atlas or C1, it affects the cervical spine. Vertical compression forces the occipital condyles downward and produces a burst fracture by driving the lateral masses of C1 apart. This is best seen as outward displacement of the lateral masses on the open mouth odontoid radiograph or on CT. If displacement of both lateral masses, measured as the offset from the superior corner of the C2 vertebral body on each side, is greater than 7 millimeters when added together, rupture of the transverse ligament is likely and the spine is unstable. Burst fractures are unstable and they affect both the cervical and thoracolumbar spine. Thoracolumbar spine. A burst fracture occurs when a vertebra is crushed by an axial load, causing fragments to displace in all directions. The lateral radiograph may show an obvious fracture of the end plates, but sometimes all that is seen is a bowing or disruption of the posterior cortex of the affected vertebra. The anterior radiographic view may show a vertical fracture through the vertebral body and widening of the interpedicular distance. The burst fracture is usually obvious on CT. The spinal cord may be injured if a retropulsed fragment enters the spinal canal. Extension injuries include hyperextension dislocation, which is unstable. It usually affects the cervical spine. Extreme hyperextension can cause a complete tear of the anterior longitudinal ligament and intervertebral disc with disruption of the posterior ligamentous complex. On the lateral radiographic view, the vertebrae may appear normal if the dislocation spontaneously reduces or if the injury is masked by a cervical immobilization collar. Prevertebral soft tissue swelling may be the only radiographic finding present. Anterior disc space widening or the fracture of the anteroinferior end plate of the vertebral body may occur. Patients usually present with a central cord syndrome. Hyperextension teardrop fracture or extension corner avulsion fracture is unstable in extension and it affects the cervical spine. Hyperextension may cause the anterior longitudinal ligament to avulse a fragment of the anteroinferior corner of the vertebral body. The height of the avulsed fragment usually exceeds its width. This fracture is more common in older patients with osteoporosis. Fracture of the posterior arch of the atlas is stable and occurs in the cervical spine. Fracture occurs from the wedging of the posterior arc between the occipital bone and the C2 vertebra. A CT is indicated to rule out an associated Jefferson fracture or a dense fracture. Laminar fractures are usually stable. They occur in the cervical spine. Laminar fractures may be associated with spinous process fractures. They may not be evident on plain radiographs and usually require CT for diagnosis. Traumatic spondylolisthesis or Hangman's fracture is unstable and affects the cervical spine. The Hangman's fracture is a fracture of both pedicles of C2 with the anterior displacement of C2 on C3. This was associated with the neck hyperextension from judicial hangings, where the noose knot is placed under the subject's chin and snaps the head backward. Suicidal hangings do not usually cause extreme hyperextension and are not associated with the Hangman's fracture. Because the spinal canal at the level of C2 is large, a Hangman's fracture does not cause neurologic injury. Injuries that are caused by a combination of mechanisms or are poorly understood include occipital condyle fractures, which are usually stable. This affects the cervical spine. Occipital condyle fractures are rarely visible on plain radiographs and usually require CT imaging for detection. Presentation is rather variable due to the proximity of multiple neurovascular structures. Neurologic impairment is common and usually involves lower cranial nerve deficits or limb weakness. Atlanto-occipital dissociation is a highly unstable fracture or injury, and it occurs in the cervical spine. It is secondary to high-energy impact. Historically, it's strongly associated with mortality. However, modern patients may survive due to better pre-hospital care or transport. The classic presentation is paralysis of the upper extremities with a lack of lower extremity paralysis or weakness, also known as cruciate paralysis. However, presentation can be variable, with a common presentation being lower cranial nerve deficits. CT may be required for detection. In radiographs in the normal patient, the distance between the bastion and the superior cortex of the dens, or the bastion dental interval, also known as BDI, should be less than or equal to 10 millimeters in adults or less than or equal to 8.5 millimeters on CT scan. In addition, the distance from the bastion to the posterior border of the body of C2, also known as the Bayesian Atlantal Interval or BAI, should be less than or equal to 12 millimeters anteriorly displaced or a less than or equal to 4 millimeters posterior displacement on a lateral radiograph. If there are abnormalities in both the BDI and BAI, this strongly suggests the existence of AOD. Odontoid or dense fractures with type 2 and type 3 being unstable, occur in the cervical spine. It frequently involves other injuries to the cervical spine and multisystem trauma. Conscious patients will usually describe immediate and severe high cervical pain with muscle spasm. The pain may radiate to the occiput. Neurologic injury is present in 18 to 25% of cases with odontoid fractures, ranging from minimal sensory or motor loss to quadriplegia. Odontoid fractures are classified according to the level of injury. CT can miss odontoid fractures if the fracture line is aligned with the cut of the CT or en face. Type 1 odontoid fractures, type 2 odontoid fractures, and type 3 odontoid fractures tend to differ on the specific location or how the odontoid is divided. So on type 1 odontoid fracture, you usually have the tip of the odontoid, speaking in non-orthopedic terms here. On type 2, you have the inferior half of the odontoid separated from the superior part. And in type 3, you have a odontoid fracture that is below the pedicle-like area of the odontoid, but it doesn't completely transverse or cut the entire odontoid. Translational fracture dislocation is an unstable type of injury, and it affects the thoracolumbar spinal column. It is a high energy disruption of all three columns of spine and is readily apparent on both radiographs and CT. Patients commonly present with severe neurologic findings. These fractures are most often unstable. However, in the absence of destabilizing rib cage fractures, lesions above T7 can be stable. Sacrum and coccyx fractures include sacral fracture. It's usually associated with pelvic fractures. Transverse fractures through the body can injure the cauda equina. Longitudinal fractures can cause radiculopathies. Central sacral fracture can present with bowel or bladder incontinence. A coccyx fracture may also occur, and coccygeal injuries are usually associated with a direct fall onto the buttocks, with resultant coccyx pain exacerbated by sitting or straining. Localized tenderness can be elicited with coccyx palpation during a rectal exam, but this is not required for diagnosis. Imaging is not needed to diagnose coccygeal fractures. Treatment is symptomatic with analgesics and use of a rubber donut pillow. The variable anatomic qualities of the regions of the spinal column cause characteristic injury patterns in each region. The exposure and extreme mobility of the cervical spine make it particularly vulnerable to injury because it is the most flexible and mobile portion of the spinal column. The cervicothoracic junction is one of the transitional zones of the spinal column, which are locations where vertebral morphology changes. This designation is important because transitional zones sustain the greatest amount of stress during motion and are most vulnerable to injury. In contrast to the cervical spine, the thoracic spine is a rigid segment with its stiffness enhanced by articulation with the rib cage. Therefore, not only is injury to the thoracic spine less common than in other regions, but this also means that the presence of a thoracic vertebral injury indicates that the patient was subjected to severe traumatic forces and the patient is at high risk for interthoracic injuries. Moreover, the spinal canal in the thoracic region is also narrower than in other regions. This increases the risk of cord injury, which is often complete when it occurs. The thoracolumbar junction, which is T11 to L2, is a transitional zone between the highly fixed thoracic and relatively mobile lumbar spine. In addition to this change in bone anatomy, the thoracolumbar junction serves as the level of transition from the end of the spinal cord, which is about L1, to the nerve roots of the cauda equina. Relative to the thoracic spine, the width of the spinal canal in the thoracolumbar region is greater. Therefore, despite a large number of vertebral injuries at the thoracolumbar junction, most do not have neurologic deficits, or if present, they are partial or incomplete. Relative to the thoracic and thoracolumbar regions, the lower lumbar spine, L3 to L5, is more mobile. Because of the width of the spinal canal in the lumbar region and the ending of the spinal cord at the L1 level, isolated fractures of the lower lumbar spine rarely injure the spinal cord or result in neurologic injury. The sacrum and coccyx form the lower portion of the spinal column. The vertebral foramina of the sacrum together form the sacral canal that contains the nerve roots of the lumbar, sacral, and coccygeal spinal nerves and the filum terminale. The coccyx, which articulates with the sacrum, consists of 4 vertebrae fused together. When neurologic injuries occur, they are usually complete cauda equina lesions or isolated nerve root deficits. Sacral fractures that involve the central sacral canal can produce bowel or bladder dysfunction. Much has been written regarding determining whether or not a particular injury is stable. Spinal stability is defined as the ability of the spine to limit patterns of displacement under physiologic loads so as not to damage or irritate the spinal cord or nerve roots. Several paradigms have been created, including the Dennis column system, which splits the spinal column into anterior, middle, and posterior elements. A spine injury is considered unstable if at least 2 columns of a particular region are involved. Although this schema and other instability scoring systems have been published, determining spinal stability after an acute injury in the emergency room is particularly difficult. This is because these injuries often occur in the setting of polytrauma, altered mental status, and severe pain, which may result in suboptimal initial imaging. In addition, many emergency rooms lack quick access to emergent MRI to evaluate the spinal ligaments. Therefore, assume any spine fracture is unstable and maintain appropriate precautions until expert consultation can be obtained from a spine surgeon. Damage to the spinal cord is the result of 2 types of injury. First is the primary injury from mechanical forces from traumatic impact. This insult sets into motion a series of vascular and chemical processes that lead to secondary injury. The initial phase is characterized by hemorrhage into the cord and formation of edema at the injured site and surrounding region. Local spinal cord ischemia ensues secondary to vasospasm and thrombosis of the small arterioles within the gray and white matter. Extension of edema may further compromise blood flow and increase ischemia. A secondary tissue degeneration phase begins within hours of injury. This is associated with neural membrane dysfunction driven by a pathologic excitation of sodium ion channels, an influx of calcium ions, and the release of glutamine. Cell death ensues from a combination of mechanisms including electrolyte imbalances, cell edema, and the formation and release of oxidative substances. The severity of spinal cord injury determines the prognosis for recovery of function, so it is important to distinguish between complete and incomplete spinal cord injuries. The American Spinal Injury Association defines a complete neurologic lesion as the absence of sensory and motor function below the level of injury. This includes loss of function to the level of the lowest sacral segment. In contrast, a lesion is incomplete if sensory, motor, or both functions are partially present below the neurologic level of injury. This may consist only of sacral sensation at the anal mucocutaneous junction or voluntary contraction of the external anal sphincter upon digital examination. Complete lesions have a minimal chance of functional motor recovery. Patients with incomplete lesions are expected to have at least some degree of recovery. The differentiation between complete and incomplete spinal cord damage may be complicated by the presence of spinal shock. Patients in spinal shock can lose all reflex activities below the area of injury, and lesions cannot be deemed truly complete until the spinal shock has resolved. A significant number of descending and ascending tracts have been identified in the spinal cord. The 3 most important of these in terms of neuroanatomic localization of cord lesions are the corticospinal tracts, spinothalamic tracts, and dorsal or posterior columns. The corticospinal tract is a descending motor pathway. Its fibers originate from the cerebral cortex through the internal capsule and the middle of the crus cerebri. The tract then breaks up into bundles in the pons and finally collects into a discrete bundle, forming the pyramid of the medulla. In the lower medulla, approximately 90% of the fibers cross to the side opposite of their origin and descend through the spinal cord as the lateral corticospinal tract. These fibers synapse on lower motor neurons in the spinal cord. The 10% of corticospinal fibers that do not cross in the medulla descend in the anterior funiculus of the cervical and upper thoracic cord levels as the ventral corticospinal tract. Damage to the corticospinal tract neurons or upper motor neurons in the spinal cord results in ipsilateral clinical findings such as muscle weakness, spasticity, increased deep tendon reflexes, and the Babinski sign. The 2 major ascending pathways that transmit sensory information are the spinothalamic tracts and the dorsal columns. The spinothalamic tract transmits pain and temperature sensation. As the axons of the first neurons enter the spinal cord, most ascend 1 or 2 levels before entering the dorsal gray matter of the spinal cord, where they synapse with the second neuron of the spinothalamic tract. The second neuron immediately crosses the midline in the anterior commissure of the spinal cord and descends in the anterolateral funiculus as the lateral spinothalamic tract. When the spinothalamic tract is damaged, the patient experiences loss of pain and temperature sensation in the contralateral half of the body. The pain and temperature loss begins one or two segments below the level of the damage. The dorsal columns transmit vibration and proprioceptive information. Neurons enter the spinal cord proximal to pain and temperature neurons. They differ from pain and temperature neurons in that they do not immediately synapse in the spinal cord. Instead, these axons enter the ipsilateral dorsal column and do not synapse until they reach the gracile or cuneate nuclei of the medulla. From these nuclei, fibers cross the midline and ascend in the medial limniscus to the thalamus. Injury to one side of the dorsal columns will result in ipsilateral loss of vibration and position sense. The sensory loss begins at the level of the lesion. Light touch is transmitted through both the spinothalamic tracts and the dorsal columns. Therefore, light touch is not completely lost unless there is damage to both the spinothalamic tracts and the dorsal columns. Each spinal nerve is named for its adjacent vertebral body. In the cervical region, there is an additional pair of spinal nerve roots compared to the number of vertebral bodies. The first 7 spinal nerves are named for the first 7 cervical vertebrae, each exiting through the intervertebral foramen above its corresponding vertebral body. The spinal nerve exiting below C7, however, is referred to as the C8 spinal nerve, although there is no 8th cervical vertebra that exists. All subsequent nerve roots, beginning with T1, exit below the vertebral body for which they are named. During fetal development, the downward growth of the vertebral column is greater than that of the spinal cord. Because the adult spinal cord ends as the conus medullaris at the level of the lower border of the first lumbar vertebra, the lumbar and sacral nerve roots must continue inferiorly below the termination of the spinal cord to exit from their respective intervertebral foramina. These nerve roots form the cauda equina. A potential consequence of this arrangement is that injury to a single lower vertebra can involve multiple nerve roots in the cauda equina. For example, an injury at the L3 vertebra can involve the L3 nerve root as well as the lower nerve roots that are progressing to a level caudal to the L3 vertebra. The pre-hospital treatment of patients with spinal injury involves recognition of patients at risk, appropriate immobilization, and triage to an appropriate facility. We presume that patients with an appropriate traumatic mechanism who have complaints of neck or back pain, tenderness on pre-hospital exam, neurologic complaints, significant injury above the clavicles, or altered sensorium that precludes accurate evaluation of the spine to have a spinal cord injury and take appropriate spinal precautions. Pre-hospital care for spinal injuries traditionally involves immobilization of the entire spine at the scene with a rigid cervical collar or similar devices plus a long backboard. However, there is little evidence that cervical collars and/or long spine boards reduce neurologic injury, spinal instability, or mortality. In contrast, cervical collars and long backboards can induce complications such as pressure sores, patient discomfort, and respiratory compromise. Spinal immobilization is no longer recommended for fully conscious, neurologically intact patients with isolated penetrating neck injury because collars can delay resuscitation and obscure neck injuries. When it comes to initial stabilization of these patients in the emergency room, we check the airway. Emergency evaluation of the patient with potential spinal injury should not differ substantially from that of any patient with multiple injuries, with the first priority being the airway. The higher the level of spinal injury, the more likely is the need for early airway intervention. For example, unstable spine lesions above C3 can cause immediate respiratory arrest, and lesions affecting C3 to C5 can affect the phrenic nerve and diaphragm function. For this reason, some experts recommend that any patient with an injury at C5 or above should have the airway secured by endotracheal intubation. Delayed respiratory compromise can occur if spinal cord edema from more caudal lesions progresses rostrally to cause phrenic nerve paralysis. Many patients can initially support ventilatory function using intercostal muscles or abdominal breathing, but they can eventually tire and subsequently develop respiratory failure. Therefore, be vigilant for respiratory compromise in patients with high cervical injuries. If safety allows, perform a brief focused neurologic assessment before sedation and intubation. We also maintain inline spinal stabilization while intubating because human cadaver studies demonstrate less cervical motion and glottis visualization with inline stabilization than with cervical collars in place, and movement of an unstable cervical spine can worsen or produce spinal cord injury. Video assisted intubation improves intubation success over direct laryngoscopy, but manual inline stabilization is still necessary to minimize cervical extension. Hypotension in patients with spinal cord injuries may be due to neurogenic shock, blood loss, cardiac injury, tension pneumothorax, or other injuries. Although hypotension and relative bradycardia are classic signs of neurogenic shock, bradycardia can also be associated with intraperitoneal bleeding or prior medication with calcium channel blockers or beta blockers. Presume that blood loss is the cause of hypotension in spinal injury patients until proven otherwise. Hypotension is initially treated with IV crystalloids. Long spine boards are associated with pressure sores, so remove them as soon as possible. Log rolling is the traditional method for board removal because it only takes a few staff and allows visualization of the patient's back and performance of a rectal exam. When it comes to the patient's history, if the patient is able to give a history, we focus on the presence or absence of historical elements included in imaging decision rules, which will be discussed later. We evaluate for symptoms of midline spine pain, painful distracting injury, paresthesias, loss of function, change in mental status, including loss of consciousness, or other neurologic symptoms, especially urinary or fecal incontinence or priapism. We pay particular attention to any symptoms indicating present or impending respiratory compromise, including dyspnea, palpitations, abdominal breathing, and anxiety, which may indicate a high cervical spine injury. On physical examination, we do a detailed initial neurologic examination. We assess the patient's mental status and note any clinical evidence of intoxication. We should focus on delineating the level of the spinal cord injury. We document the presence or absence of midline neck or back tenderness. We test motor function for muscle groups, determine the level of sensory loss, and investigate proprioception or vibratory function to examine posterior column function. We test for saddle anesthesia, which is sensory deficit in the region of the buttocks, perineum, and inner aspect of the thighs. Test deep tendon reflexes along with anogenital reflexes because sacral sparing with preservation of anogenital reflexes denotes an incomplete spinal cord level, even if the patient has complete sensory and motor loss. So the motor grading system is 0 for no active contractions, 1 for trace visible or palpable contractions, 2 for movement with gravity eliminated, 3 for movement against gravity, 4 for movement against gravity plus resistance, and 5 for normal power. To test the bulbocavernosus reflex, we squeeze the penis to determine whether the anal sphincter simultaneously contracts. Assess rectal tone at the same time. We test the cremasteric reflex by stroking the medial thigh with a blunt instrument. If the scrotum rises, some spinal cord integrity exists. Document rectal tone and sensation around the anus. An anal wink reflex or contraction of the anal musculature when the perianal region is stimulated with a pin indicates some sacral sparing. Conversely, priapism implies a complete spinal cord injury. In 2013, the American Spinal Injury Association published a revised version of the International Standards for Neurological Classification of Spinal Cord Injury. The scoring system is used by spine surgeons to document their initial examination and has prognostic value. However, the scale is rather lengthy and is not practical for initial assessment. There are three major incomplete spinal cord syndromes identified by predictable physical examination findings, although overlap in findings may occur. Anterior cord syndrome is often caused by the direct anterior cord compression, flexion of the cervical spine, thrombosis of the anterior spinal artery, with complete paralysis below the lesion with loss of pain and temperature sensation. There is preservation of proprioception and vibratory function. It carries a poor prognosis. Central cord and Brown-Séquard spinal cord syndromes have a good prognosis. Central cord syndrome is due to hyperextension injuries, disruption of blood flow to the spinal cord, and cervical spinal stenosis. Quadriparesis is greater in the upper extremities than the lower extremities. Some loss of pain and temperature sensation, also greater in the upper extremities. Brown-Séquard syndrome involves transverse hemisection of the spinal cord and unilateral cord compression. There is ipsilateral spastic paresis, loss of proprioception and vibratory sensation, and contralateral loss of pain and temperature sensation. Cauda equina syndrome is not a true spinal cord syndrome because the cauda equina is composed entirely of lumbar, sacral, and coccygeal nerve roots. Therefore, injuries to this region may produce peripheral nerve injuries. Signs and symptoms may include bowel or bladder dysfunction, decreased rectal tone, saddle anesthesia, or a sensory deficit over the perineum, buttocks, and inner thighs, variable motor and sensory loss in the lower extremities, decreased lower extremity reflexes, and sciatica. Bowel or bladder incontinence is not a universal finding. And neurogenic shock is a type of distributive shock that can occur with CNS or spinal cord injury that occurs in less than 20% of spinal cord injured patients. Loss of peripheral sympathetic innervation results in extreme vasodilation secondary to loss of sympathetic arterial tone. This causes blood pooling in the distal circulation with resultant hypotension. If the T1 through T4 cord levels are compromised, loss of sympathetic innervation to the heart leaves unopposed vagal parasympathetic cardiac innervation. This results in bradycardia or an absence of reflex tachycardia. In general, patients with neurogenic shock are warm, peripherally vasodilated, and hypotensive with a relative bradycardia. Patients tend to tolerate hypotension relatively well because peripheral oxygen delivery is presumably normal. Loss of sympathetic tone and subsequent inability to redirect blood from the periphery to the core may cause excessive heat loss and hypothermia. The diagnosis of neurogenic shock is one of exclusion. Certain clues such as bradycardia and warm, dry skin may be evident, but hypotension in the trauma patient can never be presumed to be caused by neurogenic shock until other possible sources of hypotension are excluded. Spinal shock is not neurogenic shock. The two terms have very different meanings and are not interchangeable. Spinal shock is the temporary loss or depression of spinal reflex activity that occurs below a complete or incomplete spinal cord injury. The typical presentation involves laxity, loss of reflexes, and loss of voluntary movement. The lower the level of the spinal cord injury, the more likely it is that all distal reflexes will be absent. Loss of neurologic function that occurs with spinal shock can cause an incomplete spinal cord injury to mimic a complete cord injury. Therefore, cord lesions cannot be called complete until spinal shock has resolved. The delayed plantar and bulbocavernosus reflexes are among the first to return as spinal shock resolves. The duration is variable. It generally lasts for days to weeks but can persist for months. Although spinal column and spinal cord injuries can sometimes be diagnosed clinically, diagnostic imaging is necessary to confirm the diagnosis and direct definitive care. So we have the Nexus Criteria, which is absence of midline cervical tenderness, a normal level of alertness or consciousness defined as Glasgow Coma Scale less than 15, disorientation to person, place, time, or events, inability to remember three objects at 5 minutes, or delayed or inappropriate response to external stimuli being against the normal level of alertness and consciousness. Patients should have no evidence of intoxication, an absence of a focal neurologic deficit, and the absence of painful, distracting injuries. There's also the Canadian cervical spine rule for radiography, in which cervical spine imaging is unnecessary in patients that meet these three criteria. Assessment 1. There are no high risk factors that mandate radiography. High risk factors include age of 65 years or older, a dangerous mechanism of injury, or the presence of paresthesias in the extremities. Assessment number 2, there are low risk factors that allow a safe assessment of range of motion, which include simple rear end motor vehicle crashes, patient able to sit up, patient ambulatory at any time, delayed onset of neck pain, and absence of midline cervical tenderness. And the patient is able to actively rotate his or her neck regardless of pain. The patient is able to rotate the neck 45 degrees to the left and to the right. So both Nexus and the Canadian cervical spine rule were developed in an era prior to the routine use of CT as a primary tool to evaluate the cervical spine in blunt trauma patients. So there have been studies done to compare both decision rules using CT scan as the gold standard. Nexus is only 82.8% sensitive and 45.7% specific for spine injury. And CCR has also been compared to CT scan with a sensitivity of 100 but only 0.60% specificity. So, cervical spine imaging involves plain radiography. It is important to image all 7 cervical vertebrae along with the superior border of the first thoracic vertebra. In many trauma centers, CT is done for the cervical spine. Multi-detector CT is more sensitive and specific than plain radiography for evaluating the cervical spine in trauma patients and can be performed quickly. Imaging for cervical ligamentous injury. And in patients with pure ligamentous injuries, the ligaments are disrupted, but the spine spontaneously reduces to a normal position. The resulting instability risks subsequent neurologic injury if the spine moves. Signs and symptoms include persistent neck pain or midline tenderness, extremity paresthesias, or focal neurologic findings despite normal plain radiographs or CT. MRI is the imaging modality of choice if a ligamentous injury is strongly suspected because it has excellent sensitivity for soft tissue injuries. However, there are practical limitations on its use, such as the requirement for the patient to be stable, its availability, cost, and patient tolerance for the procedure. There's also the Eastern Association for the Surgery of Trauma guidelines for thoracic and lumbar imaging after trauma. Unfortunately, I'm not going to read that. Spinal cord and neural tissue imaging is also done via MRI. Concurrent spine injury imaging can be done with CT because approximately 20% of patients with a spine fracture in one segment will have a non-contiguous second fracture in another segment. In obtunded patients, it is controversial whether a negative CT of the spine is adequate or if a subsequent MRI needs to be done. And for treatment of patients with spinal injuries, we need to obtain emergent consultation with a spine surgeon, be it a neurosurgeon or orthopedic surgeon, depending on the particular facility, on all spinal column fractures or ligamentous injuries, regardless of neurologic compromise. Thoracic and lumbar spine fractures are high risk for associated spinal cord or traumatic injuries such as aortic, intrathoracic, or intra-abdominal visceral injuries. Although many of these injuries may require admission, there are 2 types of thoracolumbar fractures that may be amenable to outpatient therapy. Compression fractures, also known as wedge or anterior compression fractures, op- occur as a result of hyperflexion during an axial load that crushes the anterior portion of the vertebra. And in addition, we have to make certain that an apparent compression fracture seen on plain radiographs is not a burst fracture, which is a compression type fracture that involves the posterior half of the vertebrae. Burst fractures may result in retropulse fragments that can impinge on the spinal canal and cause neurologic injury. Another fracture often misdiagnosed as a wedge compression fracture is the chance fracture. It occurs via a flexion distraction mechanism and involves minor arterial vertebral compression and significant distraction of the middle and posterior ligamentous structures. If, after a thorough evaluation, a stable wedge compression fracture with no neurologic compromise is diagnosed, the patient may be treated as an outpatient with analgesia, heat, massage, rest, and appropriate follow up for consideration of physical therapy. Sacral fractures that involve the central sacral canal can produce bowel or bladder dysfunction. And a notable exception to the need for emergent consultation for sacral and coccyx fractures are an isolated coccyx fracture. Coccygeal injuries are usually associated with a direct fall onto the buttocks with resultant coccyx pain exacerbated by sitting or straining. Imaging is not needed to diagnose coccygeal fractures. Treatment is symptomatic with analgesics and the use of a rubber donut pillow. High-dose methylprednisolone remains a controversial treatment in acute blunt spinal cord injury and should not be given routinely. So that's one of the special considerations we have for these kinds of patients. And there is the National Acute Spinal Cord Injury Study 2 High Dose Methylprednisolone Protocol. Indications are for blunt trauma, neurologic deficit referable to the spinal cord, and treatment must be started within 8 hours of injury. Treatment is methylprednisolone 30 milligrams per kilogram IV bolus over 15 minutes, followed by a 45-minute pause, and methylprednisolone 5.4 milligrams per kilogram per hour IV is infused for 23 hours. The use of methylprednisolone persists in some centers, And the decision to start corticosteroids should only be made in conjunction with the surgeon who will ultimately be caring for the patient and not given routinely. High-dose methylprednisolone therapy has not been found to be efficacious in penetrating spinal cord injury. So the trial that I mentioned earlier was evaluated only in patients with blunt spinal cord injury. And for patients with neurogenic shock, we initiate an infusion of IV crystalloid to correct this relative hypovolemia. If IV fluids are not adequate to maintain organ perfusion, positive inotropic pressor agents may be beneficial adjuncts to improve cardiac output and raise perfusion pressure. In target systolic blood pressure and mean arterial blood pressure, target systolic blood pressure and mean arterial pressure has limited evidence in literature. So, systolic blood pressure should be kept greater than 90 millimeters mercury, and the mean arterial pressure should be kept at 85 to 90 millimeters mercury. The aggressive use of fluids in neurogenic shock should be performed with careful monitoring because there is danger of excessive fluid replacement, resulting in heart failure and pulmonary edema. Penetrating injuries to the neck have corticosteroids as a contraindication, and emergent consultation with a spine surgeon is indicated. My source, as always, is Tintinalli's Emergency Medicine. Thank you so much.